Hello and welcome to the Critical Care Lecture. Piggybacking off of the emergency medicine topics, this would sort of be the follow-up to what happens in a critical situation when you have to admit somebody to the hospital. So talking about ICU care, a lot of it is similar to some of the concepts we've already talked about. We've already talked about a lot of the infectious disease and cardiovascular components and everything like that. So some of this will be review, but there are a couple new things or just a couple new, at least new contexts to put it into. So critically ill patients generally have some kind of a organ system or single organ failure or dysfunction, and usually undergoing acute changes in organ function, which can complicate the picture from a drug perspective because it changes metabolism. It can change how the drugs affect the body. It can make you have multiple drug regimens to counteract side effects of certain drugs and to balance out hemodynamic instability and all that type of stuff. So on top of that, you also have to manage the patient's other comorbid conditions. So if they come in and they have, say, psychiatric conditions, if they take medications for at home, you have to make sure those are successfully managed as well. And that can get tricky because your patient might not be able to take anything orally. And so critically ill patients are certainly complicated, especially from a nursing perspective, I would say is usually where the brunt is. So a lot of times, fortunately, in like Minnesota, a lot of our ICUs are pretty high quality nursing care, and usually it's a 1-to-1 patient to nurse ratio, so they can really dedicate their time to those patients. But some other couple things to consider. So fluid and electrolyte changes, you have dilution of volume, you have malnourishment possibly leading to low albumin, and the GI tract isn't usually the most reliable source, so giving anything via a feeding tube, you may or may not get absorption. Mechanical ventilation adds another layer of complication, which changes your hemodynamics by decreasing venous return, decreasing cardiac output, and decreasing hepatic and renal blood flow. Therapeutic hypothermia, if you're going to cool a patient post cardiac arrest, that's going to decrease metabolism overall, which is going to, of course, decrease the way that drugs are metabolized as well. Oops, wrong way. So just to review hemodynamics briefly, usually when we're targeting a blood pressure for a critically ill patient, you're talking about MAPS, such as mean arterial pressure. The equation's there in case you're curious, and the normal range is between 70 and 100. It's the generally accepted indicator of global perfusion. And once you get below 60, you start to get a little bit nervous about how well tissues are going to be perfused at that point. Correlates directly with volume status. You have cardiac output, which correlates with stroke volume, and preload and overall volume status. So they're all related. There's some other more advanced measurements we can do, like central venous pressure, pulmonary capillary wedge pressure. Those types of things can give us special measurements into advanced hemodynamics, specifically if you're looking at like a PCWP for like a advanced heart failure patient. And that requires some extra things. So for example, you might need a Swan-Ganz catheter inserted for that. So it's a little bit more invasive than some of the standard stuff we talk about on a regular basis. Anyway, I don't care you know about any of these things, but just to know that it is more advanced as far as what you're talking about when it comes to hemodynamics in the critically ill patient, because it's so important. Most of your patients are going to have some sort of a hemodynamic instability associated with their critical illness. So to manage it correctly is really crucial. We talked a little bit about shock so far, but certainly all three major types of shock could be present in an ICU patient. So cardiogenic, septic, and hypovolemic, and then you have the different parameters there listed. And depending on what it is, ongoing management is going to change, but your presentation of shock can look kind of similar initially. So just making sure you're replacing or supplementing using medications, no matter which shock it is, or as far as what's appropriate. So whether you have to support the heart more in cardiogenic shock situation where you're using something like a beta focused medication. Otherwise, with septic shock, your vascular resistance is down, so you want to give something that is going to work more peripherally, at least to pump blood pressure back up. And hypovolemic, you're certainly just going to want to usually replace volume, and that should help, but there might be other complications as well. Volume restoration. So if we don't treat different types of shock, you're going to end up with perfusion issues and ultimately end organ damage and failure. So first of all, if you do have to replace volume restoration is going to be critical for hypovolemic shock and also for septic shock. So it's the first step in both of those cases. So a lot of your common shock cases, I would say septic shock is probably going to be the most common shock people see on a regular basis. That's going to be a first step is fluid resuscitation. And usually we're using a crystalloid solution. We haven't really talked about solutions a ton. Crystalloids are your standard replacement solutions. So like normal saline, D5, D5 half normal, and lactated ringers, sorry. And those ones are basically just electrolytes mixed in with the water solution to a point where they're usually isotonic, meaning they're the same tonicity as blood generally. So shouldn't really burn going in. One thing you have to think about is just what you're giving the patient and how long they can tolerate it. So for example, a D5 could be problematic if your patient is hyperglycemic. Normal saline could be problematic if your patient has some electrolyte issues, but generally speaking, it's not. Normal saline will be fine for the vast majority of patients, and it's what we give as our common replacement solution. For colloids, if you need something that's going to help support intravascular volume, if you have a patient undergoing third spacing or they have some underlying malnourishment to begin with, like possibly an alcoholic patient or an oncology patient or just somebody who has low albumin for whatever reason. Albumin is going to be the most common colloidal solution you see. It gives you volume basically instantly. It helps keep volume within the intravascular space. Hedistarts and dextran, don't worry about them. They're rarely ever used, but they kind of work the same way. They're bigger, bulkier molecules in addition to fluid, and they, again, keep fluid within the vascular space. Blood and plasma can be replaced, certainly, if it's indicated, and so you wouldn't really use these as a colloidal solution on their own, but technically they would fall under that category if you did replace them. Colloids are expensive, so generally speaking, there's no reason to give them over a crystalloid unless you have that specific indication. Fluid resuscitation is going to be required if you're going to give any type of product that's going to work on the cardiovascular system, so you can't start a pressor unless you have fluid restored. So you usually start with a fluid bolus and then usually some kind of a fluid drip targeting to a specific MAP treatment goal. If MAP isn't met with fluids alone, you add a vasopressor. Pressors are going to increase blood pressure and cardiac output, usually designed to increase tissue perfusion if fluids alone can't get there. So your receptor targets, beta 1 is going to give you increased myocardial contractility and increased heart rate as well. Beta 2s are going to cause coronary arterial vasodilation and bronchodilation, working in the lungs. And then peripheral vasoconstriction is going to happen with the alpha receptors. Again, we talked about this last fall, but just basically the common pressors here. Phenylephrine, norepinephrine are probably going to be the two most frequently used ones that you're going to see, and then vasopressin. Those are kind of the three general pressors I like to keep in the back of my head. Norepinephrine is almost always going to be what you're going to use first. So if you're ever thinking about like what pressor should I use in this situation, you can't really go wrong with norepinephrine. And for those of you who will hear the name Levophed thrown around, that's the brand name of norepinephrine. It's really common. Unfortunately, it's kind of frustrating because Levophed is, I feel like it's not, the name doesn't really make a lot of sense. So anyway, that's just the way it is, and you'll hear that a lot in practice. Phenylephrine is basically a pure alpha agent, which is okay to use as well, but that can be just usually an add-on. You can do the two together, even though it doesn't totally make sense to do norepinephrine if you look at and plus phenylephrine if you look at the two receptor profiles, but actually they do work synergistically, believe it or not. But what's a better option to usually do second is vasopressin. So a lot of times they'll have somebody started on norepi, then they go to vasopressin, and then you add on the phenylephrine if you need a third pressor. Epinephrine is used in critical situations like in cardiac arrest where the patient's responding to epi, but usually we don't have people on sustained epi drips. Your body can't support a continuous adrenaline infusion for very long. It actually causes more damage than good over time, so we try to avoid that if we can, but sometimes you might have a patient on it temporarily but usually like if I have a patient who comes into the ER and they were started on epi drip like in rural hospital and they're in a helicopter, when they get here, usually the critical care intensivist is saying, yeah, let's start to wean them off or drop the epi altogether and replace it with something else. Dobutamine is your pure beta agonist, and that's going to work on the heart. So that would be a good one to start for somebody in cardiogenic shock, so your typical heart failure patient. And dopamine works on dopamine receptors and also has some alpha beta activity. Basically, it's going to work in lower rates as more like a general alpha pressor, like a phenylephrine, through a roundabout mechanism, even though it's working on the dopamine receptors. So that's another replacement option. It's not something that I see people use chronically very often. They usually, again, switch them to norepinephrine. And then milrinone is a dobutamine alternative. It's a positive inotrope. It doesn't really cause vascular changes. So you aren't going to see a lot of blood pressure increase with it, but you will see the heart both rate increase and also contractility increase. There's not really any good evidence to compare one pressor to the other. Basically, I think norepinephrine's your go-to. Dopamine's a nice one to start because it comes available in a pre-made bag, meaning you don't have to refrigerate it. Norepinephrine, you either have to compound a drip on the fly or have it refrigerated. So like at our hospital, our pharmacy makes these. So we have like a bucket of them in the main pharmacy fridge. And so we can send one pretty quickly anywhere in the hospital, but it's not something we keep on the unit. So that's a little bit of of a delay, and if you aren't working in an area that has access to sterile compounding pharmacy, you're going to have to choose something else. So like, a ambulance or a helicopter. I talked about multiple pressors. Pressors are really hard on the peripheral vasculature, and in fact, you can blow an IV line pretty easily by giving them. So I get this question a lot. We can't get a central line. Can we start the pressor? Yes, you can. You can give a pressor peripherally. However, just know that there's probably a limited time for how long you can actually do that, and eventually you want to get them on a central line. So there's no rule of thumb. It's not like you have to do it within 2 or 6 or 12 hours. You just want to get the central line as fast as possible. Dosing for pressors is a little tricky just because there's a lot of different ways you can do it. Mic per kilo per minute, mic per kilo per hour, mil per minute. Your system might have things set up a little bit differently. The nice thing is if you're using any type of an electronic medical record, it should have a standard pre-selected amount. So it might say like 0 to 10 mic per kilo per minute. But sometimes people are like, oh, what do you want to start the dopamine at? And if you're like, well, what do you normally start dopamine at? I feel like a lot of times that's the answer I get from people. But if you work in emergency medicine or critical care, it's probably a good idea to understand at least how your institution doses pressors and what the standard ranges are. And then also knowing that there's different effects at different levels. So for example, dopamine has some different effects at lower levels. So I talked about how it really affects blood pressure mostly at lower levels because it works through kind of the dopamine receptors in the kidneys, causes increased mesenteric blood flow, which ends up causing some increase in systemic vascular resistance. Once you increase it a little bit, you get more beta effects. And then ultimately you can get vasoconstriction once you increase it quite a bit higher than that. Pure inotropes are going to be good if you have low cardiac output and your fluids are on top. If you're not fluid overloaded, you'd want to make sure that you're just. Sorry, I kind of said that wrong. If you're fluid down, you want to make sure that your fluids get replaced properly before you give an inotrope because you need to have support for the heart to be able to pump something. If you give somebody an inotrope when they're dehydrated or they've lost fluid, it can be really damaging actually to the cardiac tissue, so you want to be really careful with that one. And then the thing to remember about milrinone versus dobutamine, if you have a patient who takes beta blockers regularly, dobutamine might not be super effective, especially if they took their beta blocker recently. So milrinone works in a mechanism that bypasses the beta receptors, and so you can get inotropic effects without that beta blocker. And you could use milrinone possibly until that beta blocker, half-life wears off, and then you could switch them over to dobutamine if you wanted to. I see dobutamine used more commonly in adult patients, milrinone used more commonly in peds, but certainly you can use both in either section. Well, we talked about sepsis last fall, but just to review, this is a infection that's going to be causing some sort of systemic inflammatory response. It can really be any type of infection. It doesn't have to be a bacteremia that can cause sepsis, but really you do want to get blood cultures quickly. You don't want to start your antibiotics before that, because if you kill the bacteria that's growing in the blood before you can get a culture, that's going to be difficult to narrow down treatment at that point. So get your cultures first, then get your IV agents started as fast as possible. Make sure these get continued too. So if you're an admitting physician, or admitting, I should say, either to the floor or to the ICU, you want to make sure that you check what they were actually given in the ER, and then whether or not you want to continue it. If you don't continue it, make sure you document that. There are pharmacy to dose consults for certain things, so if you're like, I don't know how to dose vancomycin, fine, but there's a pharmacy to dose button for that in most places, so pharmacists will dose some antibiotics for you. Some places might also have pharmacy to dose for other things like Zosyn or things like that. A lot of hospitals, and at least within the Alliance system, we have a lot of protocols in place. So if you put in a Zosyn dose and you neglected to look at the patient's renal function, I can actually change that without asking you. So I can just go in and change that per policy based on what our policy says we dose for renal function. So we have like a whole table of meds and renal function parameters that's approved by our Pharmacy and Therapeutics Committee, which is a bunch of pharmacists and physicians and hospital administrators that make decisions like this. So again, it doesn't really matter what you order. I can change it based on protocol if it's not correct. So, but it's always good to be safe and order it right the first time. But in case you don't, there is that fail safe. You want to control your infection source if you can, whatever that might be, and then de-escalate as your culture data comes back and your clinical picture changes or improves. Usually 7 to 10 days for sepsis is about right for antimicrobial therapy. Anything beyond that is going to be a little unusual. Definitely consider getting ID involved, especially if it's a Staph aureus bacteremia, or just if it looks more complicated. If you get fungal cultures back or something like that, certainly that'd be an ID thing. And anyone I kind of in the mindset that anyone in the ICU with a ID related indication probably should have an ID specialist consulted at least to make sure that all your bases are covered. Glucocorticoids and sepsis. So this is kind of a controversial thing, which is why I bring it up. There's some studies out there looking at these, but basically you can give glucocorticoids in a septic patient to decrease inflammation if they have severe septic shock where their blood pressure is below 90 and it's not responding to fluids should say fluids and pressors. So they've had fluids, pressors, their blood pressure is still really low. That basically means you're kind of throwing the kitchen sink at them at this point. And you're going to add on glucocorticoids to try and resolve that. There's not really any good evidence that works, but certainly it's sort of like the third line option if you've got them on 3 pressors and fluids and they still aren't responding to excuse me, or they're still hypotensive. Labs are unreliable in critically ill patients a lot of the time, so you don't really know exactly because their body's undergoing a lot of stress. So you can get plasma cortisol. You can also look at stimulating cortisol to see if they're producing it on their own. So that's a whole other thing that I'm not really going to get into at this point, but it is an option you can do. So it's called a I'll just mention it quickly. It's cosentropin stim test, and so what it means is you give this medication called cosentropin, and it works through the adrenal glands to stimulate a stress response, and you end up getting a plasma cortisol increase if your adrenal glands are functioning normally. But in a critically ill patient, sometimes they won't get any response because they're basically already tapped out at that point, and that means that because they aren't responding naturally to stress, their body can't fight with those natural mechanisms. So in that case, they might do better with a glucocorticoid on board. Usually we're giving IV hydrocortisone. Remember, hydrocortisone is basically the drug version of what our body produces naturally, and that's going to be the replacement of choice. Pain management. Critically ill patients will experience pain. They may be they may be sedated, they may be ventilated, they might not be able to express it normally. And so pain scales are designed specifically for critically ill patients that are behavioral related. You always want to treat pain first, so cover your pain, and then if you need to add more to sedate the person. Some people might be covered, like let's say if somebody's on fentanyl for sedation, they might be covered with that, or fentanyl for pain, excuse me, they might be covered with that from a sedation perspective as well. Or if the fentanyl itself isn't doing enough, you might need to add something addition for sedation. Opioids are usually what we're using. It's morphine, hydromorphone, fentanyl are going to be 3 big ones. You can use other things synergistically, acetaminophen, NSAIDs, which is fine, but know that opioids are kind of going to be your driving force. Pain goals, again, ICU nurses are well versed in how to assess pain in a sedated or ventilated patient. A lot of times you're looking at the hemodynamics too, blood pressure spikes, things like that might be indicative of the patient experiencing discomfort or pain. And usually we're looking at continuous infusion dosing versus PRN. It's probably better to do something that's regular and staying on top of the pain versus trying to catch up later. And here's just an example of how somebody might do a behavioral pain scale, like what types of things they're looking for. No, not going to test you on this, but just in case you're curious. Sedation management, we talked about this as far as induction with the ED patients. For this ICU group, you're looking at just continuing a lot of those options. Opioids may be enough. Fentanyl and midazolam is a really common sedation pathway. However, the problem is that midazolam and benzodiazepines in general are associated with longer ICU stays and increased delirium, which is a negative, of course. So a lot of times we're using propofol or dexmedetomidine if we can. So those are the 2 preferred ICU sedatives. And we talked about propofol causing hypotension. That's probably its biggest drawback. And then Precedex or dexmedetomidine doesn't have as many drawbacks. It's also not quite as, it's a little bit of a different sedative. I think we mentioned this earlier during the anesthesia lecture, but just to cover them both briefly again. So propofol, again, has a pretty rapid onset. It's lipophilic. It's got multi-phase kinetic distribution, meaning it, if you give it briefly during a short procedure, it's going to go off fairly quickly. However, if somebody's been on an infusion for multiple days, it can actually take quite a while to wear off because it distributes into the fatty tissues. It doesn't have any analgesic activity, so having some sort of analgesia on board as well is probably going to be ideal. It does have some caloric content too, so if the person's on parenteral nutrition, which we'll talk about in a minute, it's just something to consider because it's an egg white emulsion type product. And then there's something called propofol infusion syndrome. It's super rare, only for high doses over extended period of times, and it causes mitochondrial metabolism interference, which can lead to organ failure and problems that can often be fatal. Again, super rare, usually only associated with really high propofol rates for a long period of time. Precedex has a pretty fast onset too, and has a little bit longer of a duration. It can cause some hypotension as well. We don't really know if Precedex has a very good analgesic effect, but likely has some, but even so, probably needs synergy for like an add-on opioid of some kind. Outcomes are pretty good compared to benzodiazepines. So as far as like decreasing length of stay in the ICU and delirium, and propofol, it's kind of the jury's out. A lot of people tend to think that dexmedetomidine is a little bit better, but propofol is certainly popular. I would say they're both very commonly used in the ICU patients, and it kind of depends on maybe the intensivist and what they prefer. If you do have a patient who is having really low blood pressure, fentanyl and midazolam might be the better choice because they're going to cause the least amount of hypotension, whereas both Precedex and propofol cause hypotension. Precedex is the most expensive one too. It's the newer agent. It's been around quite a while now, but still relatively expensive compared to propofol, compared to fentanyl and midazolam. Richmond Agitation and Sedation Scale, or RASS. You'll hear like for sedation, they say titrate to RASS score of this, and usually it's somewhere. For an ICU patient, you just see like a 3 to 4. You don't want your patient completely unarousable, but that moderate to deep sedation is kind of what you're targeting there. Just in case you're wondering how they score RASS or what they do with RASS, it's just an example here. This is all, again, mostly nursing-driven workflow. So as a provider, you'd enter, I want this RAS score, and then they would go and, assess the patient based on these criteria. When it comes to delirium in the ICU, it gets a little tricky. This is just a chart I put on here where they surveyed some nurses a while ago. This is 2008 at this point, where they looked at using different tools in the ICU to assess delirium and what was common. And a lot of the things they found out that a lot of nurses weren't using much at all. Instead of, they were reacting to things like agitation events and commands and like things they could visually see, as opposed to some of these more proven tools. And so the point is that there's different criteria out there to assess sedation and delirium, and that it's really important. It's a kind of a critical cornerstone of ICU nursing to manage sedation correctly. And so that's important to you as a provider as well, so that you can be on top of your patient's possible delirium risk, because that can increase their length of stay in the ICU and can cause complications. So again, delirium is associated with increased mortality, and we do use a couple things to treat this. Haloperidol has kind of been the cornerstone for treating it. However, I would say that second-generation antipsychotics are preferred nowadays. I think olanzapine or other oral antipsychotics are more commonly used. Haloperidol does work quickly, though. It doesn't really reduce the duration of delirium, and it's not as effective long-term as a drug like olanzapine, but just seems to be for delirium. Delirium can be kind of tricky to manage, but you really are going to use antipsychotics as your cornerstone of treatment. And again, I would say that drugs like olanzapine are going to be preferred generally over something first generation, but it does depend on the provider as well and what they've had experience with and what they tend to see work. What you do want to do, and can be a little bit more successful with potentially, is limiting certain drugs. So remember, our big three for delirium are benzos, anticholinergics, and opioids. So if you can get away without those, that's ideal. Now, in some cases you can't. Like, you might have a patient on a fentanyl drip. It's like, well, can I switch them to propofol or Precedex? And in some cases you might not be able to, so you're just stuck with it. But you could try and limit other things. Maybe they're on something anticholinergic. The other thing I would throw in here too is, what do they take at home, and have you held something and not restarted it? Really commonly what we'll see is delays in restarts of things like antidepressants or other psychoactive medications that have short half-lives. And if you don't start those again, the patient can have kind of a agitation-related discontinuation syndrome. So it's really important to assess that and get those restarted as fast as possible. Yes, I know I said the gut's unreliable and oral dosage forms can be tricky, but it's worth trying at least to get that medication into the patient's system. Therapeutic paralysis is sort of the other thing we might continue to do. Usually if you're paralyzing somebody, it's just quickly to get intubation done. We aren't usually sustaining paralysis. However, in some cases, we have patients who are severely hypoxic and they've been intubated, they get adequate sedation and analgesia, but they just aren't responding, regardless of your vent settings and all that stuff. It's just not working. So sometimes we'll paralyze the patient because it seems like for whatever reason their body just is working against the vent. Actually, we've been seeing that with COVID positive patients. That's been something that's come up. Sometimes you might have heard about this, but like cisatracurium is the one that we use at our hospital. So it's a continuous paralytic agent. It works very similarly to vecuronium, rocuronium. It's the same mechanism of action. All the curiums or curoniums work the same. So they're basically all kind of variations of the same thing. They just have different pharmacokinetics. So if somebody's on therapeutic paralysis, they're going to be on a continuous infusion of cisatracurium, and you can kind of adjust it depending on how much paralysis you want, but usually it's kind of a standard dose. The other thing we use therapeutic paralysis for is somebody with maybe intracranial hypertension with neurologic injury, or therapeutic hypothermia. So if somebody's being cooled post-cardiac arrest, that's a person that is going to be on a paralytic drip for probably the next couple of days. We always want to use analgesia and sedation on top of this. Make sure that's controlled in addition to your paralysis. So that's going to be the kind of the cornerstone 3 treatments if you're going to give somebody paralysis. So you want your analgesia covered, sedation covered, and then your paralytic on board as well. Therapeutic hypothermia is going to be 32 to 36 degrees, 24 hours, and then you gradually rewarm the patient. What this does is it reduces the risk of neurologic injury. I think of like Han Solo being frozen in carbonite, but it's not quite that cool. Basically, what they do, if you've never seen this before or haven't talked about this before, is sometimes they'll use cooling pads. What we do is we put in this cooling catheter thing that actually pumps cold water in, and can actually has a temperature sensor on it too, so it can tell what temperature your body is at and then kind of adjust the temperature of the water. The water's not going anywhere, it's just going to the end of the catheter and cooling the patient, kind of continuously cycling in and out of that catheter. So it's not like it's pouring into the patient, but it's in a critical area where there's a lot of blood flow, so it can keep contact with blood to the point where it cools the patient over time. It's a pretty cool technology, and it prevents the need of having to, pack ice packs in the patient, which is, what we do in a pinch. So if somebody comes in and we're cooling them right away, a lot of times they'll put ice packs like in the groin and the axillary region, but at the end of the day, you want a more sophisticated solution with that, and so that's what we're normally doing. All right, preventative measures. ICU patients come with a lot of complications or risks of potential complications, so we want to prevent as many as we can. Hyper or hypoglycemia. So there was this study done in 2001 where they looked at really controlling blood sugar tightly in critically ill patients, so between 80 and 110. These results were never duplicated in any other studies, and in fact, people were really concerned that patients were going to get hypoglycemic because of too aggressive control. So the study came out in 2009 called Nice Sugar that targeted a blood glucose just less than 180 was the general target, and not being hypoglycemic. So I think what their bottom number was, like 70 maybe. I can't remember for sure. Anyway, they used a much wider range of blood glucose that was acceptable, and they found out that it was just as fine as the aggressive, if not better, and people didn't have the hypoglycemic risk. So normally what we do is some kind of a insulin infusion protocol, usually sub-Q injections or IV infusions, and then making sure that hypoglycemic parameters are watched and that sugar replacements are available, and that's all. Usually order set driven. So like, just to give you an example of how we do things at Alina, we have something called EndoTool, which sounds like endoscopy, but it's actually like endocrinology. Think about that. Anyway, it's called EndoTool. And so as a provider, you would order the EndoTool order set, which has your insulin drip. It has your like dextrose bumps in case your patient gets hypoglycemic. It has all your labs and monitoring and everything like that, your nursing communications and whatnot. And then so what the nurse will do is they will go into the EndoTool, which is linked to the electronic medical record. They'll input some criteria, and then the EndoTool will tell them what to start the insulin rate at and when to recheck the sugar. And then they'll recheck a sugar, plug that in, maybe plug in some other parameters, and then it tells them again to what to do. A lot of times you might see potassium shift when you start insulin, so you might have to supplement potassium. You might have to stop your insulin drip if you went too aggressive, or give some sugar or whatever it is. But it's all protocol driven. It's actually really, really accurate and really safe, which is good, especially when you're giving insulin. So that's usually what we're doing, just kind of as an example of how that works in real life. Stress ulcer prophylaxis is something to consider in all patients, especially who are undergoing mechanical ventilation or who have decreased platelet counts, increased bleeding risk, like elevated INR, or on a direct oral anticoagulant. And any of these other risk factors here, if they have 2 or more, you're going to treat them. The basic treatment choice is IV H2 blockers. We usually use famotidine. It's got great bioavailability when given PO as well, so it's easy to convert the person if you want to. It's cheap. IV PPIs can be used, but they're more expensive, and there's not as good of evidence associated with them. Probably would work just fine, but they just aren't really studied in that population. If patients' risk factors are no longer present, you can stop them. Make sure you stop these. A lot of times what we see is somebody was in the hospital or in an ICU, started on an H2 blocker or a PPI, and then no one ever stopped it. They got discharged on it. They've been taking it for years, and somebody finally said, "Why are you taking this?" "Oh, I started on it in the hospital a while ago, and no one ever told me to stop." And sure enough, it started as prophylaxis. The patient really has no reason for it. Remember, over time, you can get risk for C. diff and things like that with PPIs, so if you don't have to take it, best not to. General antacids, I probably don't need to say this, but they don't work in these patients. No point. Because of immobility, risk venous thromboembolism. So, and there's some other risk factors there too. But we do some non-pharmacological things like mechanical or pneumatic compression boots, which look kind of like these big, long boots that have this compression system that sort of moves blood back and forth mechanically. Compression stockings can be used, and that's usually, if the person's lower risk, if pharmacologic options are contraindicated, for example, as well. Like if you didn't want to start them on something for bleeding risk or something like that, then you might want to consider something mechanical, which can help DVTs at least. If you do want to prophylax a person pharmacologically, we use heparin. Usually 5,000 units is a fixed dose of heparin, sub-Q, every 12 or every 8 hours, depending on the patient or depending on the protocol. We used to do it depending on weight, but we actually switched all of our patients. We just do a standard Q12 now. You can also do low molecular weight heparin, which is a really popular choice as a once daily option. So this 40 milligrams Q24-hour injection is a really popular choice. Low molecular weight heparin and enoxaparin costs more money than heparin, which is why most institutions will still use regular unfractionated heparin as its prophylaxis agent of choice. IV heparin, you can do a continuous infusion prophylactically. It's just more intensive and it's easier to do sub-Q, so there's usually not a good reason to do that, but it is done occasionally. If a patient is on anticoagulation for another reason, for example, if they're on therapeutic warfarin or on a DOAC, you don't need to increase their risk of bleeding by giving them extra stuff. They're fine with that therapeutic anticoagulation. Ventilator-associated pneumonia, nosocomial infections. Good hand hygiene is always key here. I always have to say this. Why not? It's always a good reminder for everyone. But VAP is associated with increased vent use and also some other things we can do to prevent it. So assessing daily, see if we can wean them off the vent, elevating the head of the bed, daily oral antiseptic care. We use something called chlorhexidine rinse, which is like an oral solution that goes in the mouth that can decrease risk of having some sort of pathogen in the mouth get down the feeding tube. So you think about having that in the feeding tube, the breathing tube. Think about having a tube into the lungs. You have a direct line to the outside world where gross ICU bugs that are resistant to various things can kind of crawl down it and get into the lungs. And over time, that can be problematic. So those are the major risks. Ensuring good GI motility, aspiration is a risk as well, which can be caused by ventilation. So making sure that that's everything in the GI world for the patient is working correctly. Limiting antibiotics, PPIs to avoid C. diff risk can help, and not exposing patient to unnecessary pathogens as well. So making sure that, again, most of this has to do with the healthcare provider and using proper protective equipment. Nutritional support. So usually nutrition is managed by pharmacy and or dietary. This is going to be different in different institutions you go to, and I think can be some friendly turf wars with who does what here. Personally, I'd love nutrition just to take over most of this, but that's not the world we live in at Abbott, unfortunately. I don't deal with TPN patients very often, so when I do this, I kind of get a little nervous, make my resident I'm working with do it. Anyway, so there's a couple options for nutrition. So enteral nutrition is going to be preferred. If you can give somebody something using the GI tract, that's going to be the way to do it. It's less expensive. You improve healing. You reduce risk of complications. The only risk really that's difficult is that tube feedings can interfere with medication absorption. This isn't a big deal if you plan things correctly, but if you don't, you can end up with medications that don't get absorbed completely. So sometimes we'll see patients on warfarin, for example, they won't give the warfarin, like they'll give it too close to a tube feeding and it doesn't absorb, and so you'll see their INR spike because they basically missed a whole day of it. So that's something we see occasionally. For patients who can't use enteral, and I should be clear that pharmacists do not dose, at least not in my world, we don't dose enteral nutrition. This is all based on dietary, or your registered dietitian is going to do that. TPN is a pharmacy consult, so pharmacists kind of historically have done TPN. However, our dietary program has gotten more involved with it. TPN is a little trickier because you not only have your macronutrients, but you also replace a lot of electrolytes and micronutrients too, if you want to call them micronutrients. I don't know if that's the correct term, but anyway, it's kind of the electrolytes and other stuff, I should say. So a lot of times what will have happen is you get your basic input from dietary about what their fats, proteins, and carbohydrates should be, and then we'll kind of cross-reference that with our formulas, and then we will consider the more nuanced micronutrient type things. The formulas are really complicated for TPNs. They involve, again, your macronutrients, dextrose amino acids, lipids, and then your electrolytes, vitamins, trace elements, that kind of stuff. So this is what a TPN looks like. IV multivitamins are like a yellow color, which is why they're yellow. Otherwise, the solution is just clear. And then this is lipids. Lipids don't go in with the TPN. You don't mix them together. They usually go separately. They can, I think, go in the same line as long as they aren't in contact very long. I can't remember how that works. Anyway, that's not important for this discussion. The point is, we don't usually mix lipids with other things. So it's a separate bag that hangs that way. You can always tell lipids. Lipids and propofol are the only two things that look white like that I can think of. Okay, so I don't want you to know how to do this, but just in case, you come across TPNs in your career, you might just be curious as to well, how do they even think about how to do that? Well, there's a lot of different equations out there, but basically you're calculating your patient's daily caloric needs. You're looking at things like BMI, whether they're mechanically ventilated or not, dialysis, pregnant, whether they're para or quadriplegic, can make a difference as well. Those patients might just have lower muscle mass overall, which is why that can change things. Stress factors, acute kidney injury, cancer, sepsis might increase your amount of calories you give. But basically an equation would be something like this: 10 times weight in kilo plus 6.25 times height in centimeters minus age times years. And then you multiply that by your stress factor, which might be like 1.2 or something. Let's say they're mechanically ventilated. So instead of just getting the standard amount, they're going to get a multiplier of 1.2 and get an increase because of the extra stress mechanical ventilation causes on the body. Something like that. For protein goals, it's going to be part of your total daily calories. So this is kind of the second thing you calculate. So once you get your total daily calories, you want to figure out how much protein of that is going to take up. So 1 to 2 grams per kilo per day is your protein. And I didn't put it on here, but protein, lipids, and fat all correspond to a certain amount of calories per mil and how much you added in. But I'm not going to, again, I don't want to get too in depth on some of this stuff because it gets a little confusing. Anyway, then you figure out your lipids and how much lipids come in two presentations. They come in a standard 250 or 500 ml bag. So you're basically going to give the patient lipids, however many times a week to make up that amount of calories. And then, here I have it all. I should never talk before I look at my slides, right? Lipids. So your lipids should be about 25 to 30% of your total calories. And then once you get that, your dextrose is going to make up everything else. So at the end of the day, again, it's all based on total calories and then how many, like the kind of protein you should give yourself. Lipids making up around 25 to 30%, then you fill in the rest with dextrose. Hopefully dietary agrees with you and you call it good. If they don't, you just tweak it to whatever they want. That's usually what I end up doing. There's also some pre-made TPN products out there that are basically just like a standard one-size-fits-all TPN that we've been using more and more. And there's some interesting evidence that says you probably don't need to do all this, but this is the more nuanced clinical way to approach things. It's just, it takes a long time to do all this. It's a lot of just calculating stuff by hand, which is frustrating. And then you add everything else. So electrolytes, usually it's a standard setup. The problem with adjusting electrolytes in a TPN, it's very minor. So these patients, like if you change the electrolyte concentration a little bit, you aren't really giving that much more electrolyte. What you really want to do is make sure patients are on proper electrolyte replacement protocols. So if they do get hypokalemic or something, that your nurse can replace and order replacements for those. So that's a standard part of our TPN order set, that those replacement protocols all get sent in. Trace elements, there's like a standard vial of trace elements that comes as an IV form, and you just literally take it out and inject it into the TPN bag. You don't really calculate it. I'm not sitting there dosing somebody's how much chromium they're getting a day. I don't care. It's just, again, it's a standard amount. Multivitamin's the exact same way. So it's just a standard multivite that gets added to the bag, and that's all you get. So it's actually not that bad. You can really micromanage the electrolytes if you want to, but again, I don't know how much of an impact you make with that, but certainly, it could help a little bit here and there if the patient's, getting a little bit low on sodium, increasing the sodium content in the TPN a little bit. Anyway, I think I already covered those parts. As far as monitoring, really monitoring everything, complete metabolic panel, phosmag, triglycerides, CBC, LFTs, ABGs sometimes if you want to, or get a baseline. Frequency is protocol driven based on your institution. And then there's refeeding syndrome, which is something that can happen if a patient has been malnourished or hasn't been having any intake of nutrition for several days and they're started on TPN. What you can see is some aggressive shifting of electrolytes usually, and usually phosphorus is what you see as kind of the marker of this, and it has to do with just the sudden kind of increase in metabolism of the cells, and you get just shifting of stuff around, and it can cause some issues. Usually it's fine, but we do monitor the labs to make sure, like the phosphorus isn't bottoming out immediately. But again, we're trying to replace that if we can and test that. So there's usually fail-safes in place for that type of stuff. Final slide here is continuous renal replacement therapy. I don't really care you know anything about this, but it's just something interesting to talk about. This is basically what it sounds like. So it's essentially kind of continual dialysis. You've got a patient hooked up to a machine, and they're constantly getting their blood dialyzed. So we use this for a lot of different things. If somebody has really poor kidneys, it can be a solution that's better than 3 times a week dialysis. CRRT is usually, if you're on CRRT, it usually means that you're not doing great. It's probably it's not a last-ditch effort, but it's something that means you're very, very critically ill. CRRT can also be used for some other creative solutions, like you can use it to filter off toxins. You can use it to, or somebody with a bacteremia related to bacterial toxin production, if they think that's a problem, so like a streptococcus related bacteremia, sometimes we'll see people on CRRT to try and filter out the toxins that the streptococcus is producing. So something like that could be used as well. So it doesn't necessarily mean that the person's almost dead, but sometimes it is kind of indicative of this illness has progressed to the point where we have to basically constantly filter your blood to keep you at a normal electrolyte balance and everything like that. So it can be really tricky. And it's certainly intensive as far as the equipment and the solutions you have to give and all that type of stuff. All right, that's critical care. Just really quickly, the vitamin supplement lecture is slotted for this week as well. I will have it up sometime this week. There won't be any specific questions on the vitamin supplements. That's a bonus lecture, and I'll tell you basically what you need to know. I'll ask a handful of questions on the exam of it. They'll be very straightforward. And that's, again, really just sort of like a bonus lecture for your information, not really a lot of testable material. So I'll have that up sometime midweek, but for now you can enjoy this one. And then next week's final lecture will be a really short, just kind of review of med safety topics and kind of some other little things to tie things up, but it's another short lecture. So enjoy, and I'll talk to you guys next week.